Thanks, Carlin, and congrats on putting together another great course. It's exciting to be a part of this, and exciting to have all of you here. So as Carlin said, I'll be talking about PRP and stem cell therapy for sports medicine injuries. I have no disclosures related to this talk. If you look through the popular press, magazines, everything on the internet, PRP is presented often as this wonder drug. It can do absolutely anything. One treatment, you can regrow your hair. Dr. Ma, I think you're still in the back. Might want to look into this. A facial with PRP, all the wrinkles are gone. Your self-image completely resolved with PRP. If we're looking at our athletic population, PRP, again, can do anything. We see Tiger Woods, Rafael Nadal, Garrett Richards, who had a PRP injection, a believer, subsequent Tommy John surgery a year and a half later. It's like Brian Feely was talking about yesterday, Kobe Bryant, his career is saved by this, injured athletes. We can get everybody back, and then we're going to be professional athletes saving careers. So there's a lot of maybe misinformation or over excitement, and then hopefully we'll go through what these treatments really can do and what their role can be for all of us. So for this talk, an outline, first we'll start with going through platelet-rich plasma, talk about the composition and the preparation, and then some evidence for clinical applications. Then we'll go to stem cell treatments, also talking about composition, preparation, and then evidence for clinical applications. And then last, finish up with how to discuss these treatments with patients. I think more and more in our practice, people are coming in with questions. They see these ads, they see these stories of anecdotal evidence saying we can do anything with these biologic treatments, and how do we give them good scientific information that hopefully they're not being taken advantage of, and really counsel them on the appropriate use for these treatments. The goals, so I'll try to present high-quality studies when possible. If you download the slides, I have all the references on the last two slides, so if you're interested in reading through them, the full citations are there. I will focus mainly on injection-based rather than surgical-based. There's a whole other field of literature. It's about as murky for surgical-based treatments, but we'll really look at the injection-based treatments today. And then highlighting important details to evaluate the treatment and literature for these biologic treatments. So if you're looking through these studies, what are the points to pay attention to and how to interpret the meanings? So first, would just like to get the audience thoughts on platelet-rich plasma. Do you know what PRP is? Are you referring patients for PRP injections? Is anybody using PRP in their practice, or are you convinced that PRP is not beneficial? So we'll use the ARS system and get some thoughts on this. All right, great. So I think most of our audience doesn't know what PRP is, and then our next most popular choice is not beneficial. A very small subset are using it, and so we've got 17% who are in one way or another using it in their practice. So hopefully we can clarify some details so we're all clear on this topic. So to begin, simple question, what is platelet-rich plasma? So very simply, it's a volume of plasma with platelet count above the baseline of whole blood. So it's concentrated platelets in that plasma medium. There are various growth factors that are present in the alpha granules of platelets. And the concentration of these growth factors may be a powerful directed biologic treatment. So the thought is that those granules contain these factors, so TGF-beta, PDGF, EGF, VEGF, and many others. And then that you're concentrating those so you have a lot of those biologic factors present in this injectable solution. The important thing to consider is that the usage in clinical practice is really increasing. This is especially applied in older age groups. This chart here is showing the number of patients with PRP injections versus patient age. We do see a spike in younger patients, and then really we're looking in our older, 45, 50, 60 plus. So we're getting into those degenerative conditions, arthritis, tendinopathy, and then this is becoming more and more prevalent. A wide range of conditions. So this pie chart, so cartilage, meniscus, unspecified tendon, ligament, really all over the musculoskeletal system, people are using these injections. It's also important to know that it's expensive. It often carries an out-of-pocket cost for the patient, with per patient average charges reported at over $1,700. For patients, there's a study where they called around to try and just get a feel for how much people were charging for these injections. That cost ranges from $500 to $1,500. So, we're asking patients often to pay for this themselves. Most insurance companies are not paying for this. And then there are clinics that are charging quite a bit of money and may or may not be delivering what is promised. It's also important to realize that not all PRP is the same. This isn't like giving somebody Advil, where they go to Walgreens, they buy a bottle of Advil, and they have Advil. You know what's in it, and it's a controlled amount, and understand its effects and expected results. So PRP, you can prepare it in many different ways. Remember, going back to our definition, it's just that there's more platelets in this solution than blood. But what else have you done to it? This classification system is one way to kind of group these and think about it, and think about a few of the different factors that may or may not matter clinically. So first is pure platelet-rich plasma. There are no white blood cells, and then there's no fibrin architecture, so it hasn't clotted and formed into something solid. Leukocyte and platelet-rich plasma, LPRP, with that you're including white blood cells. So those will have a different effect than just the platelets alone. And again, still no fibrin architecture. It's still just a liquid form rather than more solid. Pure platelet-rich fibrin. So this, again, no leukocytes, but now it's clotted, so you can apply it directly. And then the last one, white blood cells and some architecture. These are just 6 machines. Most of the orthopedic device companies offer a PRP preparation system. They will all be a little different with the amount of platelets, white blood cells, and other factors that you get out of it. So it's important to, when you're reading the literature on this, understand how they prepared it. Was this that you can spin it a couple times? You can do all sorts of things that may or may not end up with the same product. It's also important to realize that there are patient factors that contribute to what we're getting. So again, we're taking somebody's own blood and then preparing this biologic treatment. And getting back to our medication example, like not all people's blood is the same. Like you look at a CBC and you have vastly different results in that range of normal. And then different factors that the patients are doing will contribute to that PRP composition. So one study has shown that a high-fat meal increases the peripheral platelet count in normal volunteers compared to fasting. There's not great evidence to suggest that you should counsel somebody to eat a lot or not eat, but even something that small can vary your expected yield of platelets. The time of day can affect platelet aggregation. It's higher in the morning than later in the day. There's a diurnal rhythm to this. And platelet concentration also increases. So the aggregation and the concentration, they change through the day. It's decreasing from noon to midnight. So if you're doing this in the morning, you might get a different result than in the afternoon. So when we are preparing this, there's 3 basic steps. So first step, start with a blood draw. So with this, we're just taking the patient's own blood. You do want to use at least a 21 gauge needle. The reason being, if it's a smaller bore, you can actually cause the platelets to activate, those alpha granules to open and release. Then you may not be getting the same concentrated solution that you would otherwise. Should be performed slowly to prevent premature activation of the platelets. And then you want to use polypropylene tubes to also prevent clotting and activation of the platelets. So we usually take, it's between 30 and 60 cc's depending on the system, but about that volume. Next, we're spinning them in a centrifuge. And all those different companies, they have a proprietary centrifuge, and there's an initial spin at about 1,200 to 1,500 RPMs, and that separates those components, so platelets, white cells, red blood cells. In some systems, there's a second option to spin at a higher rate, and then that will further concentrate the platelets into the same layer as the white blood cells. So going back to our different classifications, this would give you the leukocyte-rich, where you have leukocytes and platelets, whereas if you're just doing that single spin, you'll have just platelets without the white blood cells. That'll be important as we talk about some of the studies. And then the final substance is ready for injection. And so usually we get somewhere between 3 and 5 cc's. And then you want to inject this slowly. So using a 21 gauge needle or bigger, again, to prevent it from activating on the way in. And then no use of local anesthetic. That'll change the pH and will also cause premature release. And please raise your hand at any point too, if anything, if you'd like anything clarified or any questions that come up. So then that's kind of our basic background on what PRP is. Next section, I'd like to talk about the role of PRP. Yeah, in back. Yeah. Yeah, great question. I think one is because people can. Like plain like this is often an out of pocket, and so it's not that value isn't as closely worked out. And then the having the centrifuge from the company, like they'll sell those. They'll sell a blood draw kit that has all these parts. So it's just another device to purchase. And then oftentimes, clinics will offer this at a significant markup. So their costs may be low, but they're using this as a revenue generator. Just again, because it sounds good, you can, and it's a very murky area. Exactly, yeah. Works better if it costs more. So then next section, we'll talk about results in clinical practice. So first, talk about tendinopathy. So lateral epicondylitis, patellar tendinitis, Achilles tendinitis, and rotator cuff tears. We'll then talk briefly on application for muscle injury, ligament injuries, and then knee osteoarthritis. So first section, the application of PRP for tendinopathy. So the best evidence in PRP usage is probably for lateral epicondylitis. And Dr. Mishra down south on the peninsula had really done a lot of good early work on this. So one study looked at 20 patients, elbow tendinosis, failed prior treatment, and then they treated them with leukocyte-rich, so including the white cells with our platelets, and then 5 control patients received bupivacaine. So small numbers, but the symptom duration, 15 months in that PRP group, 11 months in the control group. And then what they saw, the visual analog pain score, so that bupivacaine group drops a little bit, and then you're looking out at 8 weeks later. This is the PRP where they're really improving quite dramatically. The Mayo Elbow score, so now we have the PRP at the top, where they improve quite a bit and keep improving. Bupivacaine get a little better and then start tailing off again. That effect is wearing off. So this is one of the early studies on PRP for lateral epicondylitis and really shows some promising results. So then other groups have since looked at it further, including Dr. Mishra on further work. But this study, so now larger study, double-blind, randomized controlled style, so better study design, more patients, 2-year follow-up. 51 patients in the leukocyte-rich PRP group, 49 patients who received corticosteroid. And here we see persistent symptom relief and improved function in the PRP group out to that 2-year time point. So this top, again, VAS pain score. We see the steroid in gray, it gets better. And then as we start tailing off to when we expect that steroid to wear off, pain kind of increases again. Maybe gets a little better from there, but really not as good, and significantly better in that PRP group where they improve and then continue to improve. The DASH, the disability of the arm, shoulder, and hand, we also see similar improvement at the PRP group that is lasting to a longer time point. So again, further data supporting this idea. And then now we're getting a little bigger. So now we have 230 patients, and 12 weeks, no difference. So steroid is working. 24 weeks, though, significant improvement in pain, reduced tenderness in the leukocyte-rich PRP group. So again, looking at the percentage of patients reporting significant elbow tenderness, significantly lower in the PRP group versus steroid. And treatment success much higher, yeah. Yeah, so the thought is that it's a strong anti-inflammatory in that, you have this chronic tendinopathy, chronic, changes in that tendon, and then this is encouraging the anti-inflammation and then remodeling of that tendon.
So the growth factors are anti-inflammatory?
Correct. That's the thought, yeah. Yes? Right, and then so it may just be that it's stimulating that healing response, and similar to the dry needling concept that Dr. Lee talked about. Just you're poking, you're trying to stimulate this healing. That's what we do with the steroid often, is we're just poking around to just stimulate regenerative response. But it seems like with this addition of the biologic that response is a little better. Yes?
How does it compare against saline, and how does it compare against nothing?
Yeah, and so these trials, I don't know that there has been one against saline, but we've used the steroid, or people have used the steroid and the local anesthetic as a non-biologically active control. And so there are a number of other studies where saline also has some positive benefit, especially if it's blinded. But we would group bupivacaine, steroid, and saline into those minimally active groups. The one interesting comparative group is also whole blood. So where you're excluding that complex spinning process concentration, and those whole blood versus PRP seems to be, in some studies, about the same. So that concentration step may not be adding a lot, but that still needs to be worked out further. Yeah.
What is the frequency of treatments that they study?
Yeah, so these are just one injection, yeah. And then these are all done in patients with refractory lateral epicondylitis. So you're looking at symptoms for more than 3 months. That first study was 15 months, 11 months. So these are the people that are frustratingly coming back. They've tried PT, they've tried a brace, they've tried all these, tried oral anti-inflammatories. These are the, you're selecting out the ones that are not responding, still seeing results. Yeah. Yeah, it can be. And, injecting into that area, it's not like injecting into a knee where you have a space and, the knee can hold 120 cc's plus. We're often injecting, 3 to 10 milliliters of fluid. So you're not distending anything. In this, there's no, potential space. So you're injecting into that closed space and can often be painful. Maybe they just stop complaining of it after feeling new pain in that area. So next, patellar tendinopathy. So this is a systematic review where they've collected studies in the literature on using PRP for patellar tendinopathy. They were able to include 11 studies for review, and no real difference. So this is looking at mean difference in outcomes, favoring PRPs on the left, favoring control, and these studies are just kind of somewhere in the middle. It doesn't seem like we're doing anything. They were able to find that PRP is safe, that we're not causing harm with this, and potentially promising therapy, but superiority over other treatments, such as just physical therapy alone, remains unproven. I forget the total number included, but 11 studies, and most of these are in like the 20 patient range. Like they're smaller sample sizes. Yeah. And then Achilles tendinopathy is another study, or another area that people have tried to apply this. This study, very small, so 24 patients, 12 got PRP, 12 got saline, ultrasound-guided injection, so they know right where they're putting it. And 13 patients stopped the study after 3 months because they were unsatisfied with the results. 9 of those 13 were in the PRP group, 4 were in the saline group. And looking at all outcomes, there was no difference in outcome scores, except that one difference that more people were unsatisfied with the PRP injection. So this is one, the patellar tendinopathy. It didn't look like it might not do anything, but it doesn't seem like we're making things worse. These people are actually more unsatisfied with that PRP injection. A couple others on Achilles tendinopathy. These 2 randomized controlled trials, both with 54 patients. No difference in saline and PRP when added to eccentric strengthening exercises, our mainstay treatment. And then second one, no difference between placebo and PRP injection. So again, PRP not harmful, but probably no clinical benefit. That one study that suggests maybe you make people a little more symptomatic even, probably not quite our goal. So then what about PRP for partial rotator cuff tears or tendinopathy? Again, we've seen some positive results for elbow tendinopathy. Can we do the same with rotator cuff tendinopathy? So this, looking at cortisone versus, so ACP, that's just a leukocyte poor PRP, so no white cells. And we see a slight improvement with PRP at 3 months. By 6 months, no difference. This is a common theme in the rotator cuff literature with PRP. So in this PRP and exercises, looking out to 1 year, you can see 3 different patient-reported outcomes. They all track pretty closely. A little variation in between, but no real difference. Yes.
So these are subacromial injections?
Correct. Correct. Yeah.
I mean, have they tried letting people do that?
Yeah, and people have tried, ultrasound-guided injecting at the tear site, even injecting on both sides of the tendon, but it doesn't seem to matter too much where you put it. It's still not, and it may be that space is too big, like we're not able to focus it on that area, it just dilutes too quickly.
The subacromial space is a lot larger than the
Right, and you put 3 cc's of something, and it's who knows where it goes. Yeah. But with the techniques that have been applied so far, no real difference. And then this is a recent systematic review in KSSTA, the European Knee Surgery and Arthroscopy Journal. And they looked at application of PRP for tendon disorders. This was a very large systematic review. If anybody's really interested on the topic, it has a nice summary of a lot of literature. And for patellar tendinitis, they identified 17 studies, and 2 were randomized controlled trials. And of those, mixed outcomes. They showed that PRP may have faster recovery, but the longer-term outcomes, no real difference. The Achilles tendon, 19 studies on the topic, 4 RCTs, no difference between PRP and control. Lateral epicondylitis, 28 studies, half of them as RCTs. 9 of those randomized trials showed PRP was superior to a control group. And then 5 RCTs showed no difference between PRP and local anesthetic, saline, cortisone, whole blood. And then rotator cuff tendinopathy, 8 studies, 3 randomized control trial, 2 no difference in PRP versus control, 1 PRP was better than dry needling alone. So I think the takeaway from this type of review is our current body of evidence is pretty spread. There's not a clear benefit. I think the one thing is that it does seem safe, but we may not be changing the natural history of the disease or disease process, may not be making too much of a difference. So the published studies, it is important to note that there's a fair amount of variability in the protocols, PRP formulation, as well as the control group. So the PRP formulation, whether you have the white blood cells, whether or not they're absent, that can be an important determinant of the activity of the injectable. And then the control group, are they blinded? Are they receiving exercise treatment, other treatment in addition to it, where this may not be the main driver in the results that we see. So from this, though, I would say we could consider PRP for refractory lateral epicondylitis and patellar tendinitis. And right now, it's in no clear role for Achilles tendinitis or rotator cuff tendinitis or partial tears. Any thoughts on tendon conditions and go into muscle? Yes? Yeah, and the hard, we don't have like biopsy specimens or things like that to be able to evaluate. And then the other thing is every time you're injecting that concentration, it may be a little different. So you may have more pro-inflammatory cytokines or fewer depending on the patient, how you've processed it, and so it's we're not always sure exactly what's going in. So it's hard to make broad statements on the the mechanism and the yeah. Yes. Yeah, absolutely. I'm not sure, but then also that translation, it's not always direct, and we see a lot of encouraging things in the animal model that then doesn't manifest when we put it in clinical trials. Yes. Yeah, so the question is about multiple injections. There are some protocols where they do multiple injections. The thought is still that there's not harm in this like biologic injection, aside from possible infection from just repeated needle over a weekly process. And then the real issue with that becomes cost. Like these are already something that are pretty expensive, and doing it over and over again just for a trial, for a study, or asking the patient to do it just becomes very expensive. Yes, and it'll probably.
Did the study ask for it? We use the 21 gauge, but when we injection it, is it use the same 21 gauge for all the?
Right, yeah, so you want to use a 21 or larger needle to be able to inject. Yeah, yeah.
Is anyone at UCSF using this in anything other than their research?
Yeah, so our group, we do use it, but very cautiously. And I'll touch on that a bit in the when wrapping up to like how to talk to patients about it. So for muscle injuries, another application for PRP, one study out of Toronto, this is a meta-analysis of 5 level 1 or 2 comparative studies, so higher level evidence, grade 1 or 2 muscle strains, primarily hamstring, and then they're all heterogeneous with regards to PRP formulation and dosing regimens. They wanted to look at re-injury rate, which showed no difference between PRP and control. Like, is this either weakening the muscle, which is one possibility, or even giving you a more robust healing response and then less prone to re-injury? But it doesn't seem like it's doing anything there. What they did find was the mean time to recovery was significantly lower in PRP by about 5.5 days. So injecting these patients, if you were here for the return to play lecture yesterday, grade 1 about 2 weeks, grade 2 about 3 weeks for return to play. And then the PRP versus a control seemed to decrease that by about 5.5 days. So if you're looking at an elite athlete on a tight schedule for return to play, maybe something worth considering. If you're looking at myself or someone else who, with 5 days of pain versus an injection, expense, all that probably doesn't add anything. But so that's kind of where we are on muscle. For ligament injuries, so there's been a lot of interest in the throwing athlete community on the application of PRP for ulnar collateral ligament tears. And so these are the pitchers who are going on to Tommy John surgery, where they have a ulnar collateral ligament. This study, they looked at 34 high-level throwing athletes with a partial UCL tear and had a single leukocyte pore PRP injection under ultrasound, so you know right where you're putting it. This is one that has to be done on ultrasound because you are getting close to the ulnar nerve and don't want to do any damage there. 88% were able to recover to the same level of play. One subject, so 1 out of 34, went on to have a UCL reconstruction, Tommy John surgery, and their average follow-up was just over a year. So this study, non-randomized, no control group, just treated everybody and seemed to be able to get people back to play. This past year, there was an abstract presented at our annual sports meeting where they looked through the Major League Baseball database that includes all Major League players and minor league players, so a pretty large database. And they were able to identify professional baseball players with ulnar collateral ligament tears. 133 were treated with PRP and rehab, and then 411 had rehab alone. And again, this is non-randomized, so we're not controlling for everything. This is just that teams treating medical staff decided PRP plus rehab maybe would offer a benefit. But they found that the players in the PRP group had longer time to return to throwing, so 64 days versus 51, a lower rate of return to play, 46 versus 57%, and then no difference in eventual surgical rates. And so this is not controlled, so maybe we're selecting out more severe tears that they're trying this on, whereas a more minor is being treated with rehab. But at least in this elite level population so far, doesn't seem like, maybe may not make it worse, but it doesn't seem like we're at least dramatically making it better. In the field of high ankle sprains, this study has looked at 16 athletes. They received 2 injections of leukocyte pore PRP versus a control group who just had a standard rehab program. What they found was the mean return to play time for PRP was about 20 days earlier than the control group. Also, residual pain was significantly lower in the PRP group. So for a high ankle sprain, if 20 days, 2 to 3 weeks is a meaningful amount of time. I mean, if you're dealing with a professional athlete where that could be a significant part of a football season, a significant part of a basketball season, this may be something to consider. I think for most recreational, that cost-benefit analysis probably doesn't favor it. This is certainly a small number to draw broad conclusions on, but I think some interesting evidence to further explore. Oh, absolutely, yeah. I mean, we're talking about, these are, you have like your football player who has a high ankle sprain, and you're trying to say, can we save him from missing 4 games versus 2? And we're really kind of pushing the envelope a bit. But I would not extrapolate this to a standard high ankle sprain where we can just get them better reliably, and maybe it takes 2 weeks longer. So then next, PRP for osteoarthritis. So this is a randomized control trial done out of Rush in Chicago, where they enrolled patients with mild to moderate knee osteoarthritis, and then randomized them to either receive PRP with HA or hyaluronic acid alone. And looking at their WOMAC scores, they were similar to start, and then tracked fairly similarly, but then the PRP had a slight improvement down at the end. You can see this is one of the interesting things this group did was they actually aspirated the knee and looked at the inflammatory cytokines, and did show that they were lower in the PRP group, and then after about 3 months started to rise again. TNF alpha stayed low in the PRP group the whole time, whereas it kind of spiked in the HA group. So most of these studies were just looking at patient-reported outcomes. This one's really looking at those inflammatory molecules. The IKDC score, so we saw the PRP group had a 1-point improvement in the WOMAC score, which really isn't that much. That does not meet our minimally clinically important difference. However, the IKDC score, so this is incorporating more about activity, and that improved and then kept improving in the PRP group stayed higher. Like both groups improved. This one kind of peaked and then stayed with a higher activity level, whereas the HA never quite reached that same peak and then stayed lower. So they also found that the PRP patients had a better response if they had mild arthritis compared to the HA, and then also a lower BMI. They did find the lowering of the pro-inflammatory cytokines, and they found significant improvements seen in other patient-reported outcome measures with results favoring PRP over HA. What they really found was that this seemed to allow for improved activity while maybe keeping a similar level of symptoms. If you look at a systematic review, there's been multiple on the topic, incorporating level 1, level 2 evidence. And these are generally comparing PRP to either cortisone, saline, or HA. And overall, there's a slight benefit towards PRP. All of these studies are looking at different outcome measures, but there's just a overall slight trend towards PRP being beneficial. So for arthritis, this is a tough problem where you have that mild to moderate arthritis. We wouldn't recommend a knee replacement. We know that surgical treatment doesn't really change much. If they're not seeing responses with other treatment, I think that there could be a role, but still a little early. But there is level 1 and 2 evidence that likely beneficial. If they are going to have this, it should be leukocyte poor. The leukocyte rich does not seem to have that same effect. Results seem to last for maybe up to a year, but there's no evidence to support structural regeneration, and then no long-term data on natural history. So I would say that we can definitively say that you're not going to regrow cartilage, your meniscus is not going to heal, things like that, but maybe it lowers that inflammatory process for a little longer than our other conventional injections. So then we'll touch briefly on stem cell injections, just to give some information. So the rationale is that mesenchymal stem cells have the potential to differentiate into cartilage, bone, tendon, and muscle. And they may allow for targeted regeneration of tissue. That's the hope in this field. And there are MSCs in both bone marrow and adipose tissue. So we have sources of them in our body. They seem to be able to grow into anything. Like, there's a lot of excitement in that area. There's a number of animal studies that show potential. So these studies all show that MSCs were able to regenerate in the setting of arthritis. So again, early animal work saying maybe there's some potential here. We can get stem cells from a few different sources. One is a bone marrow aspirate. This is commonly at the iliac crest. You can also do the proximal tibia, the calcaneus, other sources. And then you just aspirate through a needle, and then usually drawing 60 to 120 milliliters. The actual stem cell yield, if you look at it, is less than 1 in 100, or 0.01%, so even less than that. But so very, very small percentage, if you run cell analysis on this, that you're actually getting stem cells. Another commonly used one is the adipose-derived stem cells. This is where you take fat intra-abdominal. You can also take potentially the infrapatellar fat pad, but using basically a liposuction procedure where you're withdrawing that and then spinning it down. This study's shown up to 10%, but you're still primarily other things than just a true mesenchymal stem cell. Couple studies. So this looked at 18 patients, knee arthritis, treated with low, medium, or high doses of the adipose-derived stem cells. And then they washed out the knee arthroscopically and then injected it. They didn't see any complications, and people got better. So, all like WOMAC scores better, pain scores better. I think what's interesting, though, is if you go back, probably people are familiar with randomized control trial for the benefit of knee arthroscopy for arthritis. We don't really see a benefit with that either. People get a little better and then come back. And I would say that their figures are kind of a replication of that, kind of sham knee surgery or even just a knee washout. So the addition, even though they saw some improvement, it doesn't seem that addition of stem cells really did anything. And this is an uncontrolled trial with that treatment. A systematic review of bone marrow aspirate for knee arthritis. This only includes level 3 and 4 studies. So remember that those PRP systematic reviews, that's all level 1 and 2 evidence. That's like our higher level of evidence. These are just kind of case reports, case comparisons. And the treatment appears safe, but there's no data to support efficacy or even what you're injecting. So it doesn't seem like we're causing problems, but it doesn't seem like this is, at this point, doing anything. So the limitations, most of these studies don't have a control group. So as we've seen in these other studies, if you do a sham surgery followed by some rehab, if you do a knee lavage, people will temporarily get better. It doesn't mean that it's that intervention that's necessarily doing it, and there's no control for these. There's an inconsistent reporting of the exact formulation of the biologic treatment, so you don't always know how what they're doing, what they're putting in, or what's biologically active. That PRP injection against HA, where they they aspirated the knee at various time points, they were able to look at the cytokine activity. I think that's kind of the way we should move with these studies. But a lot of these are just, we put something in, we won't really tell you what, and then we never looked at it again in a meaningful way aside from pain. So when interpreting these studies, I would pay attention to the injection protocol, whether or not for the PRP ones, if they're injecting white blood cells, because we've seen in the joint, the presence of white blood cells doesn't seem to be as good as the absence. For the tendinopathy, it seems the reverse. The leukocyte-rich ones are the ones that are doing better. And then would always just be careful about that control group. Make sure that we're comparing to something and then something that seems like a reasonable treatment. So then how to discuss these with patients. I think more and more people are interested in this. Like, it sounds so good, but what should we tell them to be responsible clinicians? So I think I often get questions, will PRP and stem cell injections regrow cartilage? Will this regenerate my meniscus? And can this keep me from getting a knee, hip, shoulder replacement? If you look this up online, this is an actual ad from a center where they show before and after pictures of severe arthritis in a normal knee. Here is a borderline dysplastic hip with severe arthritis, and then now we have a perfectly normal hip x-ray. And I'd say no. So we are not able to regrow cartilage. We will not regenerate meniscus, and then this will not prevent replacement surgery. I think how it works, our best evidence is that it's likely a strong anti-inflammatory. And then the structure, I tell people it will not change the structure. We have no evidence, there's no data to support that. And then the cost. So most of these are out of pocket and expensive. Remember that range is like $500 to $1,500 per injection. There's also a limited duration of relief with most treatments. So I encourage people, if possible, to participate in a clinical trial if they're really interested. If they have disposable income where that cost is not changing their monthly spending habits, if they can look at it as the minimal change in their lifestyle, and they've tried these other treatments, it's not working, it might be worth pursuing, but would just be very cautious about offering it to or encouraging people to pursue it. I think we can consider it leukocyte-rich PRP for lateral epicondylitis with more than 3 months of symptoms. I think we can also consider it for that elite level athlete with a high ankle sprain, grade 1 or 2 muscle strain, where that return to play timeline is critical. This is not most of our patients, but there is a small subset where maybe that has a role and maybe it makes sense. I do think for early knee arthritis, not responsive to hyaluronic acid injections or corticosteroid injections. I know HA has a lot of questionable evidence too, but it seems in comparison groups that the PRP may be a little better. And again, this is a tough population where they're not quite ready for a knee replacement, and we don't have a lot of other options that might help them. They've tried everything else. I think if they're okay with that cost and understanding that there might not be a lot of difference, might be worth pursuing. And then refractory patellar tendonitis, going on months to years. This is something else that we can try in our potential treatments. I don't think there's current data to support use in Achilles tendonitis, rotator cuff tendinopathy, and then the role of bone marrow aspirate, the adipose-derived stem cell treatments. We do not have clinical evidence to support those at all. So in conclusion, these injections hold promise, I think, as potential treatment options for a variety of conditions. Remember that not all formulations are the same, in that we really need more high-level controlled trials before widespread recommendation of these methods. So thank you, and be happy to take any more questions if you have them.